Europe is 49 countries, nearly 900 million of people, with some difference like Russia with 143 million or Iceland with only 300,000 people. But the problem about injuries, as you can see in the slide, is about 600,000 deaths every year. When I'm trying to see what's going on in the European Union, you found it's still in 27 countries with different laws, different rules, different policies. Well, big difference between size of the countries. And you see still the number of deaths every year is huge. This slide is, I think, is quite good. Every 2 minutes, someone dies in Europe, in the European Union, by an injury. What this means is 256,000 people die every year. What means about 7 million hospital admissions, and 34 million, or above 34 million, have some kind of hospital needs. I mean, just in the little gap here is above 60 million people in the European Union have an injury every year, which means 15% of the total population. We'll see how is the difference between countries in Europe. The eastern countries, the incidence of death is quite high in comparison with the western countries. It's no big difference between north and south in the total numbers. But it's a big difference between countries and the mechanism of injury. For example, the road traffic accident, you see how in Finland is extremely low, but in Croatia is very high. I mean, talk about the European perspective is quite difficult. What is happening? The rule is that the road deaths in Europe. As to say, in practically 96% of trauma in Europe are close. Penetrating trauma is very low in numbers, and I mean what the government is doing is focusing in the road accidents, and you can see this the number of 2005, and this is 2 years ago. You can see how practically all countries have improved the survival because all the rule has been more strengthened in any country. What about the thoracic trauma? Yes, you see before, the traumas are responsible for 250,000 deaths in the European country. It's been 12 persons per million per day. 33% of this injury require hospital admission. As you know, that land traffic injuries means that 20-25% of all deaths. I mean, a huge amount. I mean, we are talking about an extremely serious problem. You see, this is what is happening in the last few years. We heard just what is happening before arriving to the hospital, but when the patient is in the hospital, what is new? I think the osteosynthesis something is happening, and for many people who worked in the 80s, the osteosynthesis in the past was very popular and suddenly disappeared for many reasons, particularly for the leak of a strong material, and because anesthetists improved the analgesia and the breathing machine. But now it's a lot of paper in the Medline talking about the indication of chest wall osteosynthesis, and exactly the same with the indication of bats in trauma. All this paper here belong to the European teams, and there are many of them. But I want to refresh is what is the situation where the thoracic surgeon should be aware about the patient, but about the pulmonary injuries. I mean, this is, you can see the chest have a road traffic accident, have a pneumopericardium and a big contusion. It's been, even with ventilation, the chance to survive for this patient are very, very low because practically is no lung functioning. Now, this other situation with the subcutaneous emphysema will look like terrible, but usually is not very important. The first thing is a pulmonary laceration. What we can do with this patient, the patient have a bicycle accident against a truck, and have a flail chest, and you can see the lung is absolutely destroyed on the top. But with some chest drain and patient, after 1 week, the lung was fully recovered. After 2 weeks, was recovered, and we fixed the instability of the chest, and the chap is doing very well. What about the acute bleeding? What we can do, this means we put the chest drain, we are waiting, but the CT scan in a stable patient, you can see that pulmonary artery branch is bleeding here. And if you don't do something quickly, these people become hemodynamically unstable and die if you're not acting rash. This is more common bleeding from the intercostal arteries, who can be resolved by thoracoscopy. But all the important thing, probably all thoracic surgeon knows about all these things have been said already, but usually all the chest trauma are involved with the polytrauma patient. For example, starting cardiac and thoracic surgery are not the same specialty in many countries in Europe. I mean, cardiac is one specialty and thoracic other specialty. Many countries have not trauma surgery specialty. Some countries have not a specialist in emergency. For example, Spain. The most of the people who are in emergency are GP who are working as in emergency. I mean, it doesn't exist the specialty. And what we can do as a thoracic surgeon? We need to know what is going on not only in the chest, because you need to do sometimes something outside the chest. Even the bone structure on the chest, we need to know what is going on with the clavicle, the scapula, sternum, or the thoracic spine. And it's very often combination the flail chest and like in this case the clavicle and the scapula broken. What we can do this, as with the orthopedic surgeon to do it, we can do ourselves. Who is doing first? I mean, someone, and personally, because the mortality is so high in thoracic trauma, I believe the thoracic surgeon should be the leadership of all this patient, not the orthopedic surgeon. It's a typical case of a flail chest with osteosynthesis, but the often thing is other case with this chap was admitted in the hospital with a hemopneumothorax at chest drain and was fixed. This is an external flail chest with bilateral broken ribs. And this is a patient with a flail chest and a clavicle fracture. Probably in this case, it's no doubt we can fix in ITU or surgically we can fix the flail chest and leave the clavicle later on. But what about the scapular fracture? It's an example. The previous patient. The patient is under the ventilation. We need to fix for the flail chest. We are doing it with a scapula. Call the orthopedic surgeon, doing ourselves. Particularly, in my opinion, is you can do as much as you can, and sometimes the orthopedic surgeon are not available to do this thing. I'm doing something else. Different thing is the sternum and the spine. The sternum is working as a fourth column of the body, and you can see this is a broken vertebra here and the sternum there. If you don't do something, the spine is bending and probably have a compression. This means you need to do some surgery. What we are doing is fix the sternum and fix the spine, but at least you must fix one of them. What about the extrathoracic injury, who the thoracic surgeon should know? This is a very useful combination: pelvic fracture, scapular fracture, and flail test. What about the abdominal trauma, always related with the lower ribs? This is a renal trauma. You can see the spleen here with this foot is injured by one of the ribs. This is the liver trauma as well. And what have the indication of thoracoscopy in trauma? Obviously, the patient needs to be stable, but it's very useful for control one of the intercostal arteries bleeding. It's no need to do a thoracotomy. If the patient is stable, you can just make a little hole, put a clip, and usually finish the operation. Early evacuation of clogged hemothorax. I'm not putting a second chest drain anymore, when the patient is not fully drained, but only one drainage. I'm doing a thoracoscopy. You can imagine how many small diaphragmatic injuries we miss. I'm not discovering, because I put it practically the thoracoscopy in many patients and discovered a small gap, but probably in the future will give some trouble. And the other indication was like a persistent bronchopleural fistula and early decortication for traumatic MPM. This is an hemothorax chest drain. You can see the lung is not fully expanded. It's still remain. Put the camera, clean everything, and the patient ready to go home. This is, for example, this is a small hemothorax. But if you don't do something, you have the chance to have an infection, an MPM, and the easy way, you can see the broken rib here, is put the camera clean. Even sometimes with sedation can do it. You don't need a general anesthesia in many cases. This is a typical case for diaphragmatic rupture. Probably nobody can miss it here. But this is other case. But you can see the rib inside. But you cannot identify the diaphragm. And when you are doing thoracoscopy, you can see a small T here. It can be fixed very easily, putting one stitch thoracoscopically, and avoid problem in the future. What are the advantage in thoracoscopy?
You have 2 minutes, Dr. Marino.
Thoracoscopy, they solve the problem effectively. The conversion rate is very low. The recovery of the patient is quicker, and decrease the hospital stay and the complication. Disadvantage, obviously, require hemodynamically stable patient, require thoracoscopic equipment, require material resources available when needed, and require a team of thoracic surgeon training this technique. And just to finish, I want to show an example. Polytrauma is a patient who fell down from the stairs and have a flail chest, bilateral flail chest, and he has one vertebra broken there and a femoral fracture. The problem was the orthopedic surgeons say they cannot fix the spine because the patient didn't tolerate the prone position. It's been what decided do the right side anteriorly, fix and the femur, and when the patient was stable, the orthopedic surgeon fixed the spine, and then we fixed the scapula on the other side, and the patient was discharged, and he's doing very well. This is the last example. Is a patient have a traffic accident. You can see the diaphragm, the broken diaphragm, and when opened to repair, the pericardium was completely split. Thank God the phrenic nerve is still in place. But the patient was quite stable. Half the mandibular fracture, half the arms and lips, with many fractures there. The hip, and we fixed the rib when closed the chest for repair the diaphragm. And after 10 months, the chap is doing very well. This is in Porto in a concert of Coldplay, who sent me a picture. What I mean is we need to be more involved in the thoracic surgeon, more involved in the trauma. We are focusing practically all daily duties in lung cancer, which is extremely important disease, but trauma is a huge number of dead people who can be helped, and many of them keep alive. Thank you very much.
Thank you.